Okay, so let's start with today's case. We have we have a 40 years old man who works full time. Just pardon me for a second. Yeah, who works full time and have two children. He's a smoker. He detailed history reveals he's has an occasional binge of alcohol with a query of independence of dependence. Sorry. Um, Okay, so he has 1 week history of a new onset seizures. This has ended up being at your emergency department of your hospital you work at, and he presented with a status epilepticus. So the detailed history of his seizures that he started with an altered awareness, head deviation to one side before generalization. Usually over the last week, he recovers within minutes, but unlike today's seizures, which occurred repeatedly and of course culminated in a status epilepticus. He has a childhood history of febrile seizures, and he has a family history of epilepsy in one of his uncles. Straight ahead, this is his MRI scan. There is, I think, there should be some slide on the further history. But let's go on to see. So he has been admitted. Um, Status epilepticus protocol, local protocol followed, and straight ahead to an MRI scan. And you were asked as a neurology doctor to have your input on his management. So I'm going to share the flare sequence here. Get a posterior fossa, medial temporals, anterior medial temporals, and then the rest of the temporal lobe here. Okay, and that's the coronals. Anything picked up your eyes? So you can simply unmute and share your opinion. Did you capture some abnormality or any abnormality in these scans? Or even anything that looks maybe suspicious? So what do you guys think? Is this a normal scan? Yes, that's correct. Also, so I was commenting about a right hyperintensity in the lateral temporal lobe. Yeah, history medial temporal lobe and insula. So there is actually, yes, there are some um, abnormal hyperintensity flare signal changes, and they are subtle, but they are there. Let's go through them slightly just to outline them. So if you notice this particular sulcus in the lateral inferior and maybe inferior temporal lobe, there are some signal hyperintensity here and effacement to these sulci. They are, if you compare the thickness of the gray matter here to the thickness of the corresponding side and the other hemisphere. This looks like this part of the cortical ribbon looks swollen. There is an effacement and it looks like there are some signal changes in the sulci here as well. So it is abnormal. It looks abnormal. If you compare also the lateral side of the right temporal lobe here compared to the cortical ribbon and the other side, that's at least fishy and suspicious. Um, Okay, so go into the rest of the scan. So it's a coronals. So you can again you can confirm that, and this is not usually a site of a site of pulsation artifacts in the flare, because there are multiple sites in the flare which can be artifactual. Usually tends to be systemic. So it depends, even if it happens at one level, it tends to happen on both sides. But this is fishy. This is not normal. Dr. Raffat is commenting about cortical vein thrombosis. Well, it might be, but there is no enough evidence to say that. But if cortical vein can present with something closer to that, for example, a vein of Lepe, that that is okay, that can happen, of course, on a flare level, but you still need the rest of the clinical imaging data to make your diagnosis. Okay, so here is the diffusion, which is really relevant to this particular case. So again, the suspicious area, maybe this is unequivocal, but the rest shows some diffusion restriction here, there. So looks like there's definitely a definite asymmetry, at least on the temporal lobe level, occipital extending back occipitally. You again, the insular region, either in the flare or in the diffusion, are a site of artifacts, or can be susceptible to be artifactual. So I'm not entirely sure if this is abnormal, but this is definitely abnormal. So this can be equivocal or accepted as normal. And the anterior, this is the anterior cingulate, which is the medial frontal region. I think this might be artifactual, but definitely the asymmetry here doesn't seem to be the case. So with this scan on the initial admission, he was admitted in the intensive care unit. He responded to the status epilepticus management protocol, so his seizures ceased, stopped out. His blood count revealed some neutrophilia, nothing else particular. His CRP is 20. Liver kidney electrolyte panels are unremarkable. His virology screen, including HIV, was unremarkable. Okay, so what is the suspicious pathology? Let's not make a diagnosis at the moment, but what do you think in a patient presenting with a new onset of seizures and and a cortical abnormality on flare and diffusion weighted images? What do you think? So if you, yeah, not a fever. No, thank you for confirming that as well. So it's no, vitally he was all right. No, that's a very good question. Yes. So Dr. Hamid is mentioning an inflammatory autoimmune. That's quite reasonable to think of. Okay, what else? So the history is really limiting. So the guy is, apart from alcohol dependence, he was all right, and the initial assessment is non-revealing apart from the MRI. So we ended up with just very few positive data to make up a picture from. So make up so the outline is really limited. Still, the differential is wide. So Dr. Rafat mentioned cortical vein thrombosis. Yes, why not? Particularly if there are some revealing history in this regard, like a headache, blurred vision, other cortical symptoms prior to the start of the seizure. So that's absolutely making sense. Infectious. Thank you, Jeremy. That's quite reasonable as well. So the start maybe started subtle. It was a subtle infection causing few seizures. I would really scrutinize back and see if there is any change in behavior, change in the language, change in any cognitive focal domain, and then culminating into a seizure. Autoimmune pathology can present with a seizure as a first presentation. The guy is a male. It's yeah, so it's a lot happen. And actually seizures, if he has a history of alcohol dependence, it's fair and square to have an alcohol withdrawal seizure, which is might be the case. There might be hidden traumatic history, but for a whole week, that's not convincing. So what can be really more convincing is that if you had a remote history of trauma, culminating into a post-traumatic epilepsy now, which can be more appealing. But again, the differential is really wide. What do you think we need to do next? Yeah, thank you, Dr. Soha. Yes, this is just summarized here. Yeah, everyone agrees on LP. That's really a good clinical sense. That's mandatory to have a lumbar puncture. Um, even that we have an MRI, this MRI is far from complete. We didn't have a contrast, didn't have a stroke protocol, we didn't have an inflammatory protocol, an epilepsy protocol. That's why, because this is despite having a high field MRI um, in the initial part of the study of the case, it did not help to solve a problem. It revealed some abnormalities, but it didn't solve the case. It didn't help us to make a case for one good reason as well. So if I'm suspicious of a vascular pathology, I would go for an MRV in addition to an MRI. If I'm suspicious of a traumatic pathology, I would add a gradient echo and look for the integrity of there has been any history of traumas. I will go for microbleeds and see how it does help. If it is infectious, I would be very reassured as well, or at least demanding to have a contrast study to see if there is any pattern of abnormal cortical enhancement or some other places to have a cortical enhancement, such as a basal, cortical, dural, whatever it is. So there are plenty of things. So MRI, even if it is accessible at the initial presentation, sometimes can be quite useless. Which is, I think so far the MRI did not help us pointing out what's going on. So he had a CSF examination. Physical appearance was okay, normal chemistry, normal cells. Viral PCR was negative. This included herpes. Um, at this stage, what you would like to add next to his workup? Yep, autoimmune and CSF. So anti-neuronal antibodies like NIMDA antibodies, LG1. Yeah, there is a list of autoimmune inflammatory panels you would like to exercise. That's absolutely a thing to think. Yeah, paraneoplastic, this would be included as well. Yeah, that's fair. So what do you think of the venous pathology? Um, there might be vascular pathology, do you think? Like having a cortical vein. So this was an initial suspicion anyway. But I think so we can have, for example, an MRV. Um, However, if a fundus examination back to the examination would be really helpful in this context. So if you just make sure that the guy doesn't have a papilledema, there is no history of headache. Once you're able to reveal the history from himself, from the patient, or from the relatives, so we can have maybe further information. So with the vascular pathology, we would need to redig the history at some point, along with a scan. Infective pathology, we needed the CSF, but now it doesn't appear to be the case. Autoimmune pathology, we need to look for the paraneoplastic and autoimmune antibodies, and autoimmune encephalitis. That's I think a mandatory to have that one. Um, and Dr. Soha is commenting that there might be suspicion of a hematoma complicating a venous thrombosis. Yeah, the leptomeningeal pattern there is fishy. So you might have either a gradient echo in your MRI, you can have a CT, or you can have a post contrast to see if that's what pattern of leptomeningeal changes is there. But for the infection, we will use the CSF examination. For the autoimmune pathology, we will use the antibodies. For the vascular pathology, we will definitely depend on the fundus examination, history taking, beside we will use a scan. So here is the point is that uh, uh, a further MRI is not the best exercise that you would have. So even if we had a non-diagnostic MRI at the beginning, still MRI is helping in shaping some details about your case, but at the end of the day, it doesn't carry the verdict of the case, of the diagnosis here. So still, even if you had a more advanced MRI, you still might not be getting what's happening or what's going on. So anyway, the case has spontaneously improved with an empirical treatment. So he was put on antiviral, assuming that it might be even not that this is not picked up by the CSF. He was put on anti-epileptic, continued to have, and he had a Pabrinex. Pabrinex is a combination of thiamine and along with pyridoxine and sometimes even added an infusion along with glucose, assuming that this might be related to an alcohol withdrawal seizures. But this was an empirical best exercise to happen. The only empirical treatment that would be wrong here is to add maybe an anti coagulant because on the suspicion that this might be venous infarction, unless you have a solid evidence of a clot in the venous system, you shouldn't do that. But I think otherwise this should be fair. Again, the empirical steroids here should not be exercised because we don't know exactly what's going on. So and there might be on the weighing the infection because this was a temporal lobe presentation. It was a focal with secondary generalization, and the temporal lobe was affected on the MRI. So that, it might point out towards an infectious or inflammatory pathology. And actually, the EEG, as Dr. Rada is suggesting, is really, really, really very important now because there might be that this is a case of epilepsy as well. So which at least it showed an intermittent sharp epileptic activity, both temporal lobes, revisiting his history back from that context that the guy is returning to baseline, good in his anti-seizure medication. So and apparently there is nothing going on so far. So we revisiting the history. The guy had occasional episodes of unpleasant deja vu with a sense of flushing over his face that tends to happen, but he did not seek medical advice for. He returned to baseline. His autoimmune profile again was right. And actually, this is a case of epilepsy presenting at his 40s. There might be the risk of or the febrile seizures and the positive family history maybe lowered his seizure threshold again with the alcohol dependence, maybe lowered that even more. And now he is frankly epileptic. And he maintained a good long-term follow-up just with the anti-seizure medications. So if that's epilepsy, so what has been going on the scan, on the MRI scans? What we have seen on the scans are recognizable changes that happens around the onset or after any given seizure onset, particularly if they are on prolonged or in status epilepticus. They're called transient post-ictal MRI changes. Transient, there is no unified terminology for them, but they are all post-ictal, and they are MRI changes happen in a certain pattern, temporal pattern, which means related to time, and spatial pattern distributed into a certain areas of the brain. Um, Overall, any patient presenting with the seizures to the emergency. So this is I have copied these figures from one of the cohort studies in one of the tertiary centers. So 16% of their patients presented with some changes in the MRI, any given seizure, and these presenting with the changes that are typical of the post-ictal MRI changes. It's quite tricky because as diagnosticians, we tend to relate things together and make a diagnosis based on the positive findings. Here you have an MRI finding and you tend to relate it to what's going on. So we are at a risk of overfitting a transient finding into making a diagnosis. So 16%, which 16 is not little, particularly with status. If a patient is status, it is more likely than not that he will have a post-ictal MRI changes. So it is very difficult to make a diagnosis of a new onset status epilepticus based on similar changes that we are going to see in the next few slides as well. Patient presenting with acute symptomatic seizures that they have something to cause a seizure, whether within the brain or even metabolic or infectious elsewhere in the body, they tend to have 25%. So it's 1 in 4. So every 4 patients you're seeing with symptomatic seizures, one of them have these transient changes. This is different even from the seizure provoking pathology. So you might have a septic focus in the brain, but also he will have some post-ictal changes that will disappear over time. And overall, a 10% of first unprovoked seizures. So say every 10 person presenting to the emergency for his first time ever seizure, uh, one of them will have a transient post-ictal MRI changes. And the mechanism is related to a cytotoxic injury. So it's a failure of the sodium potassium pump, cytotoxic edema, and the increased intracellular viscosity because of the breakdown of the cytoskeletal fragmentation. Um, the risk of developing these changes tends to more with age. If your patient is older, if his seizures or her seizures are of prolonged duration, particularly if they are status epilepticus, and if they are cardiovascularly vulnerable, metabolically vulnerable and their reserve is not as much as it should be, a borderline kidney function, borderline dehydrated patient, an alcohol-dependent patient, a geriatric patient. So all of them are more likely to have these changes than younger or maybe less people who have more of a metabolic reserve. Um, so we of course there is a pre-existing conditions as well. So see what is his if he is a mitochondrial encephalopathy patient. So it's a patient with already a known neurological or neurodevelopmental disorders. They are more likely when they have seizures tends to be prolonged, and also they tend to have more seizures. So these are the risk factors. So you would like to weigh what patient category that belongs to maybe believe or not the MRI changes related to it. And now to our main interest is that where exactly and when exactly these changes happen. So these changes can be unilateral and can be bilateral, regardless of the seizure type. And they usually involve these particular structures. So say hippocampus, both sides or one side, cortical ribbon on the cerebral hemisphere, anywhere, thalamus, and even though in the basal ganglia in some rare cases, by the way, but thalamus is a typical site, corpus callosum, and the cerebellum, which is usually across, but this is a little bit more sophistication. And sometimes they even present with a Prez-like pattern. So you have a patient who presents with seizure, and you will have a bilateral biparietal cortical MRI changes. You diagnose with Prez equally and rightfully can be a transient MRI changes, and also Prez is reversible. So it's quite an overlapping actually of the description here. Again, some more details. It tends to happen primarily in the flare and in the DWI, but they can at rare cases when there is a breakage to the blood-brain barriers, you can have some contrast enhancement as well. Of course, there are swelling. Our patient had some cortical swelling. And interestingly, they might not necessarily be of localizing value. They can be helpful in making maybe a localizable lesion. Like for our patient, we might think that he has a right temporal epileptogenic pathology, but this is not necessarily be the case. And they typically disappear within several days. I've looked up the literature. It tends to be variable, but they can persist up to a month, but they typically disappear. They tend to typically disappear unless there is severe cortical damage as a sequelae of a prolonged seizure or a status epilepticus. I'm going to share a few few images from the literature regarding regarding the same diagnosis. All the following are transient post-ictal MRI changes. So the bear in mind that the diagnosis here is made on exclusion, not just the images. So the images are suggestive. So what, for example, this patient had insular fronto temporal changes here, and also deep thalamic changes on one side, which disappeared over time. We have exercised everything to make sure he doesn't have any other positive diagnosis, and this typically disappeared over time. So we made a diagnosis at the end of the day of a post-ictal MRI changes. Assuming that we have the same scan, positive NIMDA antibodies would make his diagnosis with NIMDA autoimmune encephalitis. So the diagnosis here importantly, it's not made just on the scans. So you need the scans. You need to a good comprehension of the scans, and making sure that the changes are in the typical site, typical appearance, and they disappear or marginally or mainly disappear or largely disappear over time. But again, you would like to exercise your clinical sense before making such a diagnosis. So it is not a radiological diagnosis. It is very, very neurological diagnosis. You need to exercise all the different differentials and make sure that this is the case before concluding in retrospect that this is a post-ictal transient MRI changes. And this is a case of diffusion restriction, mainly in a parietal lobe, and with some contralateral cerebellar diffusion restriction changes happening again in the flare, but overall disappeared over time as well. This is also front temporoparietal with some thalamic changes, medial temporal changes closer to the hippocampus. This is the parahippocampal gyrus. Quite mimicking to if without this parietal bit, but it can be tricky for a PCA infarction because it involves part of the thalamus, part of the medial temporal lobe. But again, this is it goes beyond the single territory because this is an anterior circulation and this is posterior, so it doesn't fit here. Again, thalamic changes, the diffusion, cortical changes, unilateral. Sometimes it is bilateral, medial temporal on both sides. You wouldn't blame yourself if you put such a patient on an antiviral until you get the scan, until you get the CSF back. But again, this can happen temporarily on the temporal lobe and the medial temporal lobes. And that's a patient focal in the right frontal, very, very, very quite suspicious of pathology, but over time disappeared, and no other potential alternative interpretation fit more than a transient post-ictal MRI changes. And interestingly, you can find also this is called a CLOC, CLOCC, this corpus cytotoxic lesion of the corpus callosum. Tends to happen with plenty of pathologies, metabolic primarily, and tend to happen in people with status epilepticus or appear transiently in people with prolonged seizures. That's diffusion, restricted in diffusion, and appearing in the T2 later on completely disappeared following recovery. And this is another patient who had radiation for one of the gliomas. With as you can see, there was CSF shunting, and he presented with a status epilepticus following radiotherapy. These changes are like related to even both sides, and even in the caudate, the head of caudate, body of caudate as well. Diffusion changes or diffusion restriction on both cortical. You wouldn't blame yourself if you felt that this is Pres-like, but again, in the context of a status, you would not like to add a further diagnosis of a Pres in this type of patient, but you would exercise that there is no Pres related to any addition of an antibiotic or any drug, or is it related to any of the chemotherapies if this patient has been receiving radiotherapy? So you would like to think if there is any other chemotherapeutics happening, and you would like to check for the rest of it. And finally, sometimes seizures complicate the brain. So it's not transient post-ictal MRI changes, but if you had quite enough prolonged seizures, a patient might end in hypoxia, which can be seen. I think if you practice enough in the acute settings, you would find some hypoxic insults even culminating on a brain or even on hypoglycemic out of the seizure. But again, this is a very peculiar metabolic pattern, bilateral lentiform, bilateral head of caudate. And these are primarily out of hypoxia, but not out of the transient epileptic changes, but might be a complicating picture here. The take home, if you find a patient who presented to a seizure, presenting to you with a seizure, undiagnosed seizure, so he had a cortical, thalamic, hippocampal MRI changes, any of them, or in combination, you would like to think about the time when the MRI happened, and is there a diagnosis of epilepsy or not? And what's the age and metabolic profile to if there are any risk to develop transient post-ictal MRI changes? And you would like to include the other non-imaging evidence of pathology. And to this, I conclude. If you would like to add any more questions, I would be more than happy to respond to it. Actually, I would like to thank one of my colleagues, Dr. Raad. Right now, I'm not sure if he's around today, but actually, the idea behind this session is a couple of cases that were, I think, most fitting to be transient MRI changes rather than any vascular problems or any other infectious or inflammatory pathologies.